share screen first. Enter screen. Maybe we'll just do entire screen. Okay, can you see the slides now?
Yes po, Doc.
Hold on, let me. Give me a few minutes, sorry. All right, I think we can start now. Has any one of you, or maybe hopefully some of you, have viewed the video lectures that was given just yesterday? By anyone who has seen it? Yeah. So the video lecture consists of 5 parts, I think 5 parts now. It's quite long, and we uploaded them so that you can have a little more in-depth study on the topic, because this is quite long. It seems simple, but it's quite long, and what's the difference from what we are going to do today? We don't want to take up too much time here, because we know the attention span, especially online, is probably less than 30 minutes. So we'll try to finish in less than 2 hours, hopefully. What we're going to do here is have a few simple sample cases, of course, concerning biliary diseases, and then I'll try to make a more concise summary of uh, the 5 sections of the video lectures. Try to make it brief and more practical explanation, but you will need to view the video lectures for a more in-depth knowledge. And don't forget, you still need, despite viewing the video lectures, you still need to read your book. Uh, and what we're going to talk about today, I listed them down. There will be stones, of course. That's the most common problem of the biliary tree. Talk briefly about tumors, some diagnostics, particularly explained to you ERCP and PTBD. It's also explained actually in the first part, no, of the video. But we will try to put them all together, no, para merong flow. And then possibly, if we have time, show you a few videos of actual surgery that we do, so that you will understand when we discuss this, you'll have a better perspective. Mm. All right, so let's start with our first case. Very little data here. 44-year-old female presenting at your clinic or emergency room, or even probably just a relative asking you about upper abdominal pain. Now, I want you to imagine this scenario and then think now of a list of differential diagnosis of patient presenting with upper abdominal pain. Very general. You can type your answers in the chat box. There should be at least 10 differentials here, maybe 20 even. Nobody has typed anything yet. No ideas? Upper abdominal pain. Yes, of course. Number one, cholecystitis, because that's the topic today. What else? Pancreatitis, yes. GERD, yes. These are very common. Yes. So we have three. Peptic ulcer disease, of course. Yes. Very good. Four. Gastritis, yes. Hepatitis, correct. Cholangitis, good. Yeah. Okay, so we have at least five, six maybe. Differential diagnosis. There can be more. Don't forget, yes, simple indigestion, yes. Oh, give everything. Torcardenas, cholangitis, hepatic abscess, yes. Now, do not forget, we were only given limited data. Yeah? Don't forget, when you have the chief complaint, it may not be limited to that area. Don't forget about the lower abdomen conditions too that can spread to the upper abdomen. Liver cirrhosis, okay. Oh, now, thank you for those. Uh, let's try to limit a bit. Two, instead of upper abdominal pain, now narrowed down to the epigastric area. I think all the differentials you gave will still be applicable, even if we narrow down a bit to epigastric pain, right? Gallstone disease, uh, acid-related problems, they will still be here, right? Mm, how about if we change this to going further right, to the right upper quadrant? Mm, now, more and more, we seem to be narrowing down to biliary diseases. But do not forget that sometimes even those that you gave for upper abdomen or epigastric, for example, the acid-related problems, gastritis, peptic ulcer disease, they can also present with right upper quadrant pain, even left upper quadrant. Uh, but if I say that our patient, 44-year-old female, has right upper quadrant pain radiating to the back, then that is highly suspicious now of gallstone disease. Perhaps less of acid-related problems, right? Um, and also what's important here, I always tell my preceptorial groups, look at the demographics. Our patient falls within the category of well, it's actually traditional three Fs or even four Fs of fat, female, 40. Uh, this is the typical profile of somebody who would have gallstone disease. But I say traditional because nowadays we see them in males, we see them in females, although still more common in females overall. We see them in old people, 60, 70. We see them in people as young as 20 or even less. This is probably related to our diet, very high cholesterol Western diet. Mm. Uh, but the traditional three Fs and four Fs are here, 44 female. Um, Now, let's add something. Aside from the right upper quadrant pain, now our patient has jaundice. This essentially almost rules out the acid-related problems and really focuses on the biliary disease now, right? Um, but let's try to change the case to earlier we had probably the three Fs in the previous patient. Now you notice the patient is a 60-year-old male. And I only wrote here with jaundice, implying there may or may not be pain. Now, how does this affect our impression or our diagnosis. Number one, uh, if you have any patient with painless jaundice, then until otherwise proven, you should be thinking of malignancies. When we say malignancy, I will explain later. This can be anything that obstructs the bile duct, of course, thereby producing jaundice. In most of the malignancies, they will sooner or later have abdominal pain. However, if you have the patient presenting with painless jaundice only, that has to be proven, or to be malignancy has to be ruled out first and foremost. And also, you look at the age of the patient. We are in the 60s, the fifth decade or sixth decade. This is the most common age group where biliary malignancies are diagnosed. So that's why demographics is always important. Take note, though, that we do see malignancies in younger patients, 40s, even 20s. But of course, when you take exams, we will not really give you the extremes. Most of the time, we will give you the common scenarios that we see, the typical one. Now, let's explain here. So what I'm going to do right now is this is the synthesis of uh, the five or four videos that you are going to view eventually. Not working, sorry. Wait. Sorry, give me a minute. Mhm. Let me try something else. Sorry, I think it's not working on Zoom. Uh, you can have a 2-minute break first. I will stop share first. Okay, are you ready, guys? Sorry for that. Um, I'll try a different way. It's not working on Zoom. So I'll try this. Can you see my screen again? You see the blank page and the drawing, the line?
Yes po, Doc.
Okay, thank you. Uh, all right. So let's see. So here I'm going to draw the liver, and then uh, the video duodenum, the C loop of the duodenum. Gallbladder is attached to the liver underneath, and you have this narrow neck and leading to the cystic duct, which is connected to the bile ducts. Here you have the right and the left intrahepatic ducts. Common hepatic duct goes down. When the cystic duct joins, it becomes the common bile duct leading down to the ampulla, right? And let's use yellow here for what should be joining here, the pancreatic duct that goes this way. So now if you have stones in the gallbladder, the normal physiology is the bile comes from the liver and comes down through the extrahepatic bile ducts. Oh, a sphincter is normally closed. There is a muscle in the sphincter when you are in fasting state, and therefore the bile, the biliary tree fills up and stores bile in the gallbladder. That's why your gallbladder is more distended in the fasting state, and diagnostics, especially an ultrasound of the gallbladder, you want the patient to fast for at least 8 hours. That will fill up and distend the gallbladder, and therefore, any tiny lesions here, including tiny stones, you will be able to see better. Um, in contrast to having a contracted gallbladder, and that obscures some of the lesions or stones inside. Whenever you eat, the food that passes protein, acid from the stomach, oil especially, fats, stimulates the gallbladder to contract, and then it empties into the bile duct and the sphincter relaxes, and then so the bile flows into the intestine and helps absorb food, helps emulsify food for better absorption in the small intestine, especially oily food. Now, if you have as the gallbladder contracts, then the stones go to the narrow part of the neck or the cystic duct. And then imagine that distended gallbladder filled up with bile, pushing against an obstructing stone that will cause pain. And that pain is can be mild, can be severe, and then the gallbladder tends to relax a bit and then contracts again. So you develop colicky pain that we describe or we call biliary colic. So that is the symptom of gallstone disease, biliary colic. However, if you have a stone that, oh, sorry. So when that gallbladder relaxes, sometimes the stone uh, moves back and the pain is gone. And that's why in patients with what we call chronic calculus cholecystitis, the pain pattern is typically intermittent. It can be every few days, it can be every few weeks. Some people will rarely have pains, maybe once a year or less, but they all fit the description of what we call chronic calculus cholecystitis. In anyone who has stones, whether asymptomatic or having signs of biliary colic or chronic cholecystitis, um, they can one day have the stones stuck there totally, sorry, let's erase this. And then if the stone gets stuck in the neck or cystic duct here and won't budge, then what happens is the whole gallbladder swells eventually within a few hours, and the pain becomes continuous, severe, later on may have fever as the inflammation progresses, or even progresses to infection. And that is what we call acute cholecystitis. So the symptoms become more intense, more longer lasting, may not be relieved by painkillers. And so you have right upper quadrant pain and tenderness, fever, vomiting, and the patient most likely will be rushing to the emergency room because of the persistent pain. Now, sometimes the stone, instead of getting stuck here in the cystic duct, especially if it's tiny stones, and therefore tiny stones doesn't mean less dangerous, they can pass through the cystic duct, which is normally around 3 millimeters only in diameter. So anything smaller than that can squeeze through, or bigger than that, say 0.5 cm. But because of the persistent contraction of the gallbladder, eventually a bigger stone may squeeze through and dilate the cystic duct, and therefore it enters the common bile duct and gets obstructed somewhere downstream where it's narrowest near the ampulla. If it obstructs that part, then the bile flow all the way up to the liver is obstructed, and then you now have elevation of bilirubin, and the patient will present eventually with jaundice. So when you do the exam, diagnostic exams, ultrasound, what you're looking for is number one, stone in the gallbladder. If you're suspecting acute cholecystitis in the ER, then you would look for other signs like thickening of the gallbladder wall, some fluid around, we call it pericholecystic fluid, sign of acute cholecystitis. But if the patient has jaundice, then you want to look for the effect of the obstruction, which is dilatation of the biliary tree. And depending on where the dilatation ends, for example, it ends, the whole common bile duct is dilated, then probably means the obstruction is somewhere near the ampulla, periampullary, whether that's a tumor or stone. If you see dilatation that ends here in the common hepatic duct, and that probably means obstruction is somewhere in this area, the cystic duct junction and common hepatic duct junction. And either that can be caused by what we call benign strictures or tumors or stone in there. And in the setting of acute cholecystitis, the obstruction in this area can happen without a stone inside the bile duct. The stone is right here in the neck, a big one, plus edema, eventually compressing externally on the bile duct, therefore effectively narrowing the functional lumen of the bile duct, but without intrinsic problem in the bile duct. So that external compression by swelling and the stone compressing externally on the hepatic duct is what we call Miritzis syndrome. You will encounter that if you read how do you spell Miritzis? Mrizzi apostrophe S, Miritzis syndrome. So it's usually seen in the setting of cholecystitis, where a big stone obstructs the hepatic duct externally. Why is that important? Because if you have stones in the bile duct, then let's go back to stones in the gallbladder. The treatment, you probably know already, is what we call cholecystectomy. Remove the gallbladder. Oh, the liver went away. Sorry, let's throw the liver back. The liver. Okay. So cholecystectomy will address the problem. However, if you have stones in the bile duct, you will have to, in addition to removing the gallbladder, you need to take out the stones in the bile duct, and that can be done endoscopically through ERCP with the scope passing from your stomach down your esophagus, stomach, and to the second portion of the duodenum. Open the ampulla. We normally cut the sphincter to loosen it and allow bigger stones to pass. And then with an instrument, like what we call a basket, we pull out the stone from there. Or if that is not successful, then we do a procedure called common bile duct exploration. And that can be done by cutting open the bile ducts and then extracting the stone from above. And that is done together with the cholecystectomy, whether laparoscopic or open. Or in some cases, if the cystic duct is dilated enough, we can actually avoid opening the bile duct and we do transcystic common bile duct exploration, take out the stone. So that is if there is a stone in the bile duct. But if the problem is external, for example, mirices, then simply by removing the gallbladder without opening the bile duct will relieve the obstruction. So that is for stones. Now, sometimes because of jaundice, it's not a stone, but a tumor. And the tumor can be coming from the bile duct. Bile duct itself, we call it cholangiocarcinoma. It can be anywhere from the pancreatic head. As it gets bigger, it will eventually constrict or obstruct the bile duct. It can be from the ampulla in itself. We call that an ampullary cancer. Or even a duodenal tumor that as it grows big, also it will eventually obstruct the ampullary opening. So all those, sometimes when they are big, it's hard to tell where it really came from. If they are small, we can see on a detailed CT scan or MRI, we can tell where the origin is, if it's bile duct or pancreatic head or even ampulla. But if it's big, it just obstructs everything, and we simply label them as periampullary tumors as a whole. And they normally will present with jaundice with or again without abdominal pain. So, now other sites of tumors can be, aside from distal, can be here, near the bifurcation of the right and left bile ducts. And that is what we call perihilar tumors, commonly due to cholangiocarcinoma. In the video lectures in your textbook, you will learn that there are 3 types of cholangiocarcinoma. One is intrahepatic. The other one is extrahepatic, which is further divided into perihilar and the distal cholangiocarcinomas. No, intrahepatic cholangiocarcinomas, because they may not obstruct the bile ducts, or if they ever obstruct, for example, it's here, obstructing this part, the bile ducts here, maybe not enough to cause jaundice. So usually intrahepatic cholangiocarcinomas just presents as a mass, much like an HCC or hepatocellular carcinoma. But perihilar and distal cholangiocarcinomas usually will present with jaundice because they obstruct significantly the bile ducts. And the treatment for tumors, if it's HCC or intrahepatic cholangiocarcinoma, is hepatectomy, removing portion of the liver that bears the tumor. For distal, it will be like any periampullary tumors, which is what we call a pancreatoduodenectomy, taking out the bile duct, the gallbladder, the entire duodenum. Sorry, there's a blind area here, that the lower part, let's do it. And the stomach, distal stomach or duodenum. So this whole area is removed in what we call pancreato or pancreaticoduodenectomy, also known by the name Whipple's procedure or Whipple's surgery. So if the tumor is hilar, it's here, then a Whipple will not be enough, and neither will be a liver resection like this. Because both the right and the left hepatic ducts are affected, you will need to do more than half liver resection. Half liver resection is what we call a hemihepatectomy, whether that's on the right side, that's called right hemihepatectomy. On the left side, it's called left hemihepatectomy. If we have to do more than half, for example, if the half is here, we have to do more than half, extend to this part. Let's say tumor is more on the left because it won't work on the right. So we have to do, sorry, erase. Too dirty, sorry. All right, do more than half. There. That's what we call an extended left hepatectomy. Or extended right hepatectomy, meaning take this whole 3/4 of the liver. And normally we can survive. You will learn in your liver lecture that you can survive with as little as 30% of remnant liver left in the normal liver. Cirrhotic livers, it has to be bigger because it's functionally compromised. So that is an extended hepatectomy that we do for hilar tumors. Now, let's move on to other diagnostic and therapeutic procedures. If you have an obstruction like a stone or tumor, let me draw a different one. Or maybe I'll try to use, let's use this one. Oh, hold on. Stop again. Share. PowerPoint got stuck. Let me close first the PowerPoint. Mhm. Ah, let's have a 2-minute eye break first again. Sorry, I'm gonna have to log out first and I'll log on again. Have a pee break first. right. Welcome back. Welcome back to me. Can you hear me again?
Yes po, Doc.
And try to share screen again. Uh, Enter screen. Okay, let's use this. Can you see the screen now?
Yes po, Doc.
Let's see. But there's no. I cannot. Okay, okay, get it. I think the drawing doesn't work when it's on Zoom somehow. The pen doesn't work. Okay, let's use this drawing, yellow. All right, let's draw some stones here. Here, for example. Okay, are you seeing it within the baldock?
Yes po, Doc.
So let's assume this one is causing obstruction in the proximal bile ducts. Now, ERCP, ERCP is endoscopic retrograde cholangiopancreatography. Endoscopic, it goes through the stomach. Again, down here, open the ampulla, may or may not do a sphincterotomy. We call it a sphincterotomy because it cuts the sphincter muscles, and inject contrast upstream. That's why it's called retrograde. It's going upstream against the flow of bile. And cholangiogram means visualization of the bile ducts through an X-ray study using a contrast. While the pancreatic duct can also be visualized, that's why it's called pancreatography. So after confirming that the contrast doesn't go up because there is what we call a filling defect, uh, meaning there's only partial obstruction, then you can actually attempt to insert a wire basket and then extract that stone. Now, in cases where it is impacted and cannot be extracted, but the patient is having complications of the obstruction, especially an infection called cholangitis. It can be an emergency. When there is cholangitis, you need to address the infection fast because it can progress to sepsis within 24 hours, especially in high-risk patients. So there has to be some form of relief of the obstruction. If they cannot take out the stone in one sitting, then they can insert a tube. We call it a stent. Pass beside this obstruction, whether it's a tumor, a stricture, or stone, going up where there's no obstruction, and the other end of the tube goes down into the duodenum. So that tube, it has a hole. So that's what we call a stent, a biliary stent. And then the other hole is here. Okay, so that's a biliary stenting procedure, done endoscopic. However, if the obstruction, you see, when you insert a stent, you will need some space to insert that tube. In fact, first they insert a guide wire and then they slide this stent over the guide wire. But you can imagine if the obstruction is complete, there's just no space to insert the guide wire through the side and bypass the obstruction. Then there's no access upstream. Then the option would be to do it the other way, go from above, passing through the liver, and then puncture a bile duct within the liver, and then thread that tube downstream. It can stop here because it will still drain the bile. If you need it to go through, then you can do that. But usually you do that because it's totally obstructed. That's why you're going upstream. And the stent stops here. So this is what we call PTBD, percutaneous, because it goes through the skin, transhepatic, going through the liver, biliary drainage, PTBD. the diagnostic part of that is called a PTC, percutaneous transhepatic cholangiogram. Um, uh, and PTBD means therapeutic, meaning you are really draining the bile duct, and then we leave the stent. The difference is with the PTBD, the catheter is left outside and then connected to a bag, like a urine bag and a Foley catheter, like that. With the ERCP, the stent is internal, so there is no external tube for the patient, more comfortable and more physiologic because all the bile is passing through into the duodenum just like normal. Yeah. Therefore, you have less of the fluid and electrolyte disturbances in an ERCP drainage. So that is for ERCP and PTBD. Any questions so far? Are you understanding what we are talking about here? Does that give you a good idea of the whole topic? No questions? Okay, if you have any questions, just type in the chat box, or you can speak up. Sometimes I might not notice the chat box. Just speak up because anyway, there are a few people going to use the microphone. Now, I think we can stop share again. The PowerPoint keeps hanging. I think the problem is the video embedded in the PowerPoint. Maybe stop share again. I will try to maybe take out the video from the PowerPoint. Zoom slideshow. Let's see. Sorry, take a break again. I will try to fix this. I think it's the video in the PowerPoint. I will remove the video. All right, I'm back. Um, Now can you see now? There, it moves. Okay, so we will move on. We have, I think we'll be done in 30 minutes max. Mm. So now more about stones. So we've discussed the diagnostics and a few therapeutics, that is. From here on, I'll just show you some actual images and videos so you can relate more to the reality. And so there are different kinds of stones. You will see in the video lecture the pathophysiology of the formation and its relation to the types of stones that we see. So there are small, medium, large stones, as you see here. There is largest. There are those that look like corn kernels or cornic even. And you have stones that look look just like any stone on the road or in your garden, perhaps. Mhm. And these are actually, this kind of stone is probably more pigment. Pigment type of stone is usually found in what we call primary stones in the bile duct. Mm. Primary stones in the bile duct means the stone is formed within the bile duct, as opposed to secondary stones, meaning it came from the gallbladder and passed through the cystic duct and into the bile duct. So secondary stones in the bile duct is more common. The primary stones are more common in certain regions, and we are one of them for uh, Southeast Asia, East Asia, Africa. Anything in common with those regions? Partly, only partly, uh, low socioeconomic status, maybe because it's infection related, whether that's bacterial or parasitic infection. And there are stones that look like deadly weapon, like this one. And there are pearly stones, and those are crystalline. And the stones can be solitary or they can be multiple, like this one. If you can count, this is something like 200 plus 216 or some or so. These are 300 plus stones. And here the whole gallbladder is filled. 600 plus. I counted them. Would you believe I really counted the stones? It's out of curiosity, because when we opened the gallbladder, it was really filled. And we actually took time to count it, but I only recall it's 600 plus stones. And that's my record so far. So now, let's go back to the case earlier, the second case, 60-year-old male with jaundice. So when you are now suspecting a biliary pathology, and there is jaundice, maybe there's pain, maybe there's not. You're thinking hepatitis, perhaps you're thinking uh, a stone or even a tumor. The first thing you would normally do is request for two things. One is the imaging, uh, but at the same time or before that, you will want normally to request for what we call the liver profile. And in the video, I showed you an example of a liver profile test, uh, like this one. Um, can you try to interpret this? This liver profile is not of this patient, okay? But this is the example I gave in the video lecture. If you can try your hand in interpreting this liver profile and type your impression. When I say impression, I'm implying the possible etiology of the jaundice in this case, or in any case that has this kind of liver profile pattern. Type in the chat box. So we have probably two exercises on interpretation of liver profile. I think this is important. Mm. Elevated total bilirubin, yeah. So what's the interpretation? What's the cause? So for those who haven't read or haven't viewed the videos yet, a brief introduction. Uh, Obstructive type, total B1, B2. Okay, here's a brief clue. ALT, AST, these are hepatocellular enzymes usually seen in inflammation or injury of the liver. Total bilirubin, any jaundice, if you have bilirubin more than 3 milligrams per deciliter, here it's 2, the patient will normally present with jaundice already. Below 3, but above normal, may present with icteric sclerae, not necessarily yellowing of the skin. Uh, if conjugated bilirubin is elevated, no, sorry, let me rephrase. Usually, obstructive type of jaundice will have elevated conjugated bilirubin more than unconjugated. And those that are non-obstructive usually will have more of unconjugated hyperbilirubinemia. Now, alkaline phosphatase is in the biliary canaliculi usually increases with biliary obstruction, although not exclusive to biliary obstruction. Now, the keywords take note when I said more of conjugated bilirubin versus unconjugated, more of, meaning it is not exclusive to obstruction or non-obstruction, and it's not specific, but most of the time you have more of either conjugated or unconjugated hyperbilirubinemia. Any answers? None yet? Only one possible obstructive. If you suspect obstruction, one thing you want to look at is the alkaline phosphatase. If it's high, then that's more consistent with obstruction. The higher it is, then the more consistent with obstructive jaundice. If it's normal, makes you think twice. No other answers? Try just type anything. Choledocholitis. So if it's choledocholitis, that would imply also obstruction. It's an obstructive type. It falls under the category of obstructive jaundice. So first, when you have jaundice, algorithm goes obstructive versus non-obstructive because the non-obstructive are usually what we call the medical jaundice. For example, hepatitis, and also what we call prehepatic, that is hemolytic diseases can cause jaundice, right? And usually hemolytic diseases will elevate the unconjugated bilirubin because that is before conjugation inside the liver. And then after the conjugation process in the liver, if there is any obstruction in the bile ducts, then all the bile is already conjugated by then. Yeah, probably non-obstructive prehepatic could be. So, all right. ALT, AST normal. Yeah. Intrahepatic, only if, okay. So we have three answers already, the three possible ones, the obstructive, you have the hepatic, and the prehepatic non-obstructive. Again, prehepatic means anything before uptake of unconjugated bilirubin. For example, hemolytic disease. Intrahepatic can either be inflammatory, for example, hepatitis, or an inborn error of metabolism, one of the enzyme deficiencies that prevent conjugation of bilirubin or excretion from the hepatocyte, of bilirubin. Um, Now, if it's inflammatory, it's hepatitis, it's a form of injury to the hepatocyte, then we can expect the hepatocellular enzymes such as ALT and AST will be increased. No. And here it's normal, and that almost rules out an injury or inflammatory cause. Now, obstruction, number one thing we want to look at is if it's obstructed, because that concerns the surgeon, if it's obstructive type. We look at first two things, conjugated bilirubin and alkaline phosphatase. Alk-phos here is normal, conjugated is elevated, but then again, I said more of. So it is elevated, but if you look at the unconjugated bilirubin, it is actually more elevated than the conjugated, or equal at least. That means both are elevated. So usually obstructive type, conjugated is more elevated over the unconjugated. Um, so the conjugated bilirubin in obstruction can be uh, higher, while the unconjugated either normal or a little bit lower than the conjugated bilirubin. So in severe obstruction, everything can go deranged, but you look at the ratios, you see if it's very disproportionate. So this one being that conjugated, unconjugated are equally elevated can be, yes, intrahepatic cause, but definitely not inflammatory. If ever, it will be probably enzyme deficiency, or it can still be a prehepatic cause. Oh, oh. Now, there's so did you get that? Did everybody understand that? Maybe for today, if you haven't read your book, you'll be confused now. But at least when you go back to your book later on or view the video lecture, you will now be able to remember what we were talking about today, and you'll be able to better understand because you have a wider perspective now. Now, let's try another one. This is new. I haven't put it there yet. This is a new referral. I will show you actual. Where is the result of that? But the result is, I'll just mention it. The ALT and AST, you can write it down on a piece of paper. Write it down on a piece of paper. ALT and AST are mildly elevated. Total bilirubin is 10, markedly elevated. Conjugated at 8 and unconjugated at 2 milligrams per deciliter. You get that? And alkaline phosphatase is 600 plus almost 700. So that's markedly elevated. Try interpreting that. Did you get that? Again, ALT, AST, mildly elevated, total bilirubin and conjugated, markedly elevated. Unconjugated, slightly elevated. Alk-phos, markedly elevated. Now, while you analyze that, I will try to answer the question in the chat box. Considering the age, is enzyme deficiency? Good question. Is enzyme deficiency unlikely? Okay, it depends. Now, there are several types of enzyme deficiencies that cause jaundice, some of them neonatal, and some people grow up with it, with intermittent jaundice. It depends on the degree of the deficiency, the severity of the illness, because some people will have marked jaundice. In fact, they're jaundice all their lives, or intermittent jaundice, or the jaundice is very subtle, or only elevation of bilirubin, such as this. A bilirubin of 2 milligrams per deciliter, sometimes the jaundice is hardly noticeable. And only when they seek consult for even other condition, it's an incidental finding. So it is still possible that it could be an enzyme deficiency. Yeah, but yes, most of the deficiencies being inborn will be diagnosed earlier, either pediatric age or early adulthood. Um, Next question. Obstructive may be the second case. Obstructive. Okay, good. Now you're learning it. Yes, indeed, it's obstructive. In fact, we are suspecting a tumor in the second case. And we will see that, we will confirm that with imaging. But yes, obstructive jaundice with hepatitis. Secondary. Okay. Since it's been mentioned here, obstructive jaundice with hepatitis, I assume what you mean, or I hope what you mean, is not the common viral hepatitis. When you say, which is hepatitis A, hepatitis B, um, I assume what you mean is some form of biochemical hepatitis. What is that? Meaning you have, yes, inflammation, you have very severe jaundice, you are expecting normal, very high conjugated bilirubin, maybe close to normal or normal ALT and AST, but it elevated mildly. How can that be explained? If you have very severe, especially prolonged obstruction, the consequence is eventually there will be some form of damage to the liver itself, and therefore there will be inevitably hepatocellular injury or inflammation. Or it can be complicated by cholangitis, in which case the alphos being canalicular enzymes will increase, and because cholangitis can affect the whole liver because there are bile ducts all throughout the inside of the liver, ALT and AST can increase too. So yes, obstructive jaundice with some form of biochemical hepatitis can explain why everything is deranged. But again, you do not look at the individual components individually. You need to look at the whole thing. That's why it's a whole set of tests. It's a packaged liver profile. And then you try to correlate the ratio between each value. Okay, I hope you understand that. One thing we ignored here is part of the liver profile is the, yes,
Wait lang. 12. Mga 12. Hmm.
I'm assuming that's not for me. Somebody turned on his mic.
Pwede. Nandito din naman ako. Ngayon.
Let's turn on. There are 300 of you, so how can I tell which one is I should turn off? So let's
Sige,
remove
lover.
this one.
Thank you.
All right. So I was saying we ignored TPAG, TPAG, total protein, albumin, globulin. Yeah, because as explained in the lecture, albumin is synthesized in the liver and therefore reflects liver function. In terms of jaundice, we don't really use this. But when we
Wait
do
lang.
liver surgery, we need the albumin. And when we diagnose patients with cirrhosis, we need the albumin because that's part of the scoring of the degree of decompensation of the liver. Okay, so now, oh no. Up again. Stop share first. Stuck again. Ah.
May piniprep kasi ako.
See the PowerPoint hanging again.
Ha?
Who is
Bugok yun.
uh, yeah, but maybe Bakay. Let's see. Turn off your. Anyway. Okay, I'm going to. Yes, thank you. Going to just show you a video. Hope it works. Of just a simple surgery, laparoscopic cholecystectomy, so that you can this hopefully may help you actually better remember what you are studying as it relates to not only anatomy but the pathophysiology of disease. So in laparoscopic cholecystectomy, we insert what we call the trocars. Are you seeing it? No, you're not. Hold on. Share. Here again. See this one. Are you seeing the screen?
Yes, Budo.
Okay, let's wait. I'll play it. So we insert trocars. That's where the instrument goes through. We insert that. We insert 3 or 4. And the view here is the camera is in the umbilicus. So therefore you are looking going up to the head part. And what you see, of course, is liver, and you see the gallbladder that's attached to the undersurface of the liver. And in this uh, okay, now here you see the gallbladder, that's the fundus part, and then the body, and then the narrow area here is what we call the Hartmann's pouch, or the neck of the gallbladder. That's why, because it's narrow, if the stone gets stuck here, a big one, then you develop biliary colic or cholecystitis. Cystic duct should be somewhere around here under this thing. This is a lymph node. We call the node of Lund. Some call it Callose node. It's the lymph node draining the gallbladder. And then underneath that is probably where the cystic duct is, somewhere along this path here. And I see what is probably the cystic artery here. Now, where is the common bile duct? Notice in this picture here, there is nothing like, remember the drawing? It's like this, cystic duct, common hepatic duct, common hepatic duct, common bile duct. But in the actual thing, it doesn't really look exactly like this. Can may or may not be close, but definitely the common bile duct is not very well outlined, right? That's because it's covered by the fatty tissue here that we call the hepatoduodenal ligament. So that covers everything here. the bile duct, the arteries there, the hepatic artery. So therefore, this thing on beneath is the stomach and duodenum area. This is probably the constriction of the muscle here we call the pylorus. Therefore, that makes this the distal stomach or antrum and probably the duodenum. So this thing that covers it, including this part, is called the hepatoduodenal ligament. And that should be where the bile duct is. Therefore, bile duct is somewhere here. Yeah, somewhere here is bile duct. Maybe, maybe not. In fact, this is actually clearer compared to many other patients. If there's acute inflammation or very bad chronic inflammation, sometimes everything's just thickened and hard to decipher. So why is that important? Remember, as part of cholecystectomy, there is a complication, dreaded complication we call bile duct injury. And therefore, everything has to be clearly identified. And to help us, we have what we call from this border here of the here, cystic duct going up here to the border of the liver. I'll make it thicker because it's the same color. Oh, no, sorry, like this. So it's not perfect, but because the gallbladder is being retracted. And the other side here medially is the border of the hepatic duct. So this area here, this space should be a triangle that we call the hepatocystic triangle. Some people call it the triangle of Callot. And that means that's where the instrument goes through so that it can pass behind and loop around the cystic duct and we can clip or tie this. And this is supposed to be what we transect and not any part of the bile duct. But if there is very severe inflammation, it's not as far like this. Everything is just either right on top or adherent to each other. And therefore, by cutting the cystic duct, we may develop some bile leaking from the bile duct. Or worse, you take out a segment of the bile duct together with the entire specimen. So that is classified as what we call bile duct injury, which is a rare but dreaded, potentially catastrophic complication of cholecystectomy, whether open or laparoscopic. Delete. All right, so we'll proceed with the video. I want you to take note. Let me go back first to this part. Take note of the liver. Yeah, maybe here. Is this getting in the way? Okay, notice here on the medial part, this would be the going to the left side of the patient, this on the right side of the patient. The liver is a little blunted. And here, it's sharp. If you recall your second year medicine, what is the normal liver edge, sharp or blunt?
Recording
Let's see chat
stopped.
box. Sharp or blunt is the normal liver. Searching, Googling, sharp or blunt is what we want when we see liver. Therefore means healthy liver. Answers on the chat box.
Sharp po.
Tagal ng Google, ah. Okay, sharp, yes. So, like this one here on the right border, now that is sharp. And here a little bit blunt. So you see blunt in cases of fatty liver, or is typically most common is fatty liver. And the diaphragm, by the way, is up there. Now let's continue. So we dissect the hepatoduodenal ligament, strip that tissue so that we can expose what we call the cystic duct and the cystic artery. So let's skip. Also on the upper side, we try to dissect until, see, we are able to make a hole within the triangle. And there should be only two structures left, the cystic duct and the cystic artery here. This is a posterior branch of the cystic arteries. Sometimes we divide it, sometimes we leave it. But these are the two important structures going to the gallbladder, meaning there is no bile duct there because bile duct should go into the liver. If it doesn't go to the gallbladder but instead goes up, that means we are close to the bile duct and we have to adjust our dissection. So this kind of view is what we call in surgery. You will hear that when you rotate during clerkship, the critical view of safety, meaning it's safe to clip. And you can see cystic duct here and cystic artery, which we will clip later. So there, the cystic duct has been clipped. Sorry, it jumped. I think doesn't show. Oh, there's a lesion on the liver, probably a hemangioma. Very common benign liver tumor. So the cystic duct here has been clipped with two plastic clips, sometimes metal, and the artery has been clipped too. And now we will take out the gallbladder. So that's what we do when we perform cholecystectomy. Okay, now I will try to show you one last video as before we finish. For sorry, lost it in the one that's hanging. Oh.
Kaya po.
All right. Okay, I will share screen again. And okay, now let me orient first. The top part of the video here would be the head, and this is the lower.
Wala pa share ko.
Ah, walang share, sorry. Share. Okay, so what you're seeing in the top part of the video, when we do surgery, open, that is, open cholecystectomy or biliary surgery. Sorry, it's hard to draw because the pen is not working. Okay, it's like this, right? And umbilicus here. In open surgery, we do a right subcostal incision like this. So this is it, a right subcostal incision. Therefore, the head is up there and the foot down here. We are doing what we call a common bile duct exploration, meaning to take out stones, right, or any obstruction within the bile duct. So this one is a creep show. So you're seeing the front. So this will be the bile duct here, running this way, and that's the opening in the bile duct. Sorry, it's a bit bloody because of noisy assistant. It's a bit bloody because of the inflammation
Recording in
and
progress.
cholangitis. So that is an ascaris worm. And I'm showing you this because remember I mentioned earlier that parasitism is one common cause of primary bile duct stones. And
Recording
in
stopped.
intrahepatic stones, we call hepatolithiasis, something we see
Recording in progress.
Hey, sorry, I'm mute. Yeah. So anyway, what you saw was a case of ascaris worms in the bile duct, in the bile duct, and it's an important cause of primary stones and hepatolithiasis, especially here in the Philippines. We see that quite a lot here, compared to our Western counterparts, where their bile duct stones are mostly secondary stones coming from the gallbladder and usually cholesterol stones. Primary stones are more of the pigment type related to infections. Okay, so that will be the last video and last slide. When you look at the video lectures, you will see on the background of every slide an outline of the biliary tree, and that is there deliberately to like brainwash your subconscious into the anatomy of the biliary tree. Why? Because as you probably have seen and realized today, much of the disease symptomatology is related to the anatomy and physiology of that drawing. So again, read further your textbook, and let's see if there are any more questions. There is, but only yesterday na lectures kasi wala daw yatang uploaded. Anyway, I will check again with the coordinator if there is, but we'll make sure to have it uploaded soon. I will check later today. So any more questions? If there are none, then we can call it a day for surgery 2. Thank you for your